Good evening to everyone and welcome to today's session. Jessica, Akshay Purohit, Surendra, Ram Sundaram, Venkatesh, and many more who are all online. Good to see almost 21 online students. So, Doctor, every day we all meet, we study together, and we finish a set of questions. And in the next 26 weeks, it's a wonderful time available. Almost 150 days of time is available. We will be able to finish all the 19 subjects review. So once more, drawing all your attention to the most celebrated coaching program where we have 20 years of history of creating the toppers, of mentoring and helping the people. So I like to quickly take your attention to one of the interesting places. We started this program called Top NEET PG 2021 and FMGE in 250 hours of the live class. Every day, Monday to Saturday, we are live online interactive session, 6 p.m. to 8 p.m. A lot of students asked it, sir, please, why don't you come at the same time every day so that we schedule ourselves. I try my best to do that. From June 1st to November 30. Actually, you all had been following me since the June 1st onwards. So we started with gynecology and obstetrics. So between Monday to Saturday, almost every day, 2 hours, we have about on average 10 hours a week. Next 26 weeks, we will study together and finish about 250 hours. So June 1st to June 6th, June 8th to June 13th, like that, we have 26 weeks. So please go to this link and you get the schedule also, schedule of the classes. Once this live broadcast is over, the video is removed and we made it available on the onlinembbs.com video library. So even if you miss because of any reason, you always have PowerPoint and the video available for you to do the revision. But what my point is, video is not that, it is not that important. There are so many videos available. But every day sitting together and solving 60 to 70 questions and going by a schedule and subject after subject, covering by the time November 30th, we should be in a position to cover all 19 subjects, most crucial topics, MCQ-based discussion. So I once more invite all of you, Top NEET PG 2021 FMGE in 250 hours, live class every day, 2 hours with Dr. Murli Bharadwaj. Please tell all your friends. Some students say, if we have this faculty, it's great. 19 subjects, 19 faculties is great. But honestly, I'm telling you, doctor, any faculty or any teacher, what is his job? If somebody teaches you surgery, can you go and do surgery? No. Preparation for surgery for NEET PG or FMGE is all about knowing around 5,000 important points in surgery, from which 30 questions are going to come. So I have a confidence that any subject you give me, I know what are the high-yield topics and how I can drive it into your mind and equip you ready like a war missile to attack the examiner. So that is the reason I run this 19 subjects. Don't think that it will bore you. You will not know how you finish the subject. Let's play with the subject. We also have another program called 180 hours revision with dream faculty. So we have a dream faculty, almost 19 subjects. Every subject has its own faculty. There's one more program available. But generally, what I understood is we have those faculty teaching and made available to you. But you also have Dr. Murali Bharadwaj sitting with you, holding the pen and studying every day along with you to make you to revise the common questions, high-yield topics, everything to go for the exam. So let us make the beginning of this great journey together. Now, doctor, we had been with obstetrics and gynecology in the previous sessions. I hope you have an opportunity to revise them, and until the next Saturday in our schedule, we have gynecology obstetrics every day 2 hours. Okay, so now amniotic fluid is the next topic. Keep punching the answers, doctor. A case of 35-week pregnancy with hydramnios, marked respiratory distress. How do you want to clinically manage polyhydramnios? Is the favorite question of the examiner. Basically, it is by amniocentesis, by removing the fluid. Now, which condition is associated with polyhydramnios, oligohydramnios, etiology, everything you should know when you go to the exam tomorrow. So, doctor, cleft palate, if there is any bladder isotrophy or posterior urethral valves or renal agenesis, they are all associated with oligohydramnios. So, doctor, you should remember the etiology, definition, clinical management of polyhydramnios, which is the favorite topic. So what is polyhydramnios? Increased production of amniotic fluid or decreased consumption. Univovular twins, anything that increase placental mass will lead to polyhydramnios. Similarly, maternal causes, pregnancy-induced hypertension, severe generalized edema. And if there is any anencephaly, esophageal atresia, they are the classical underlying cause. And anything that increases the placental mass, like a chorioangioma of large placenta. Hydrops fetalis resulting from RH incompatibility, severe anemia, hemoglobinopathies, particularly alpha thalassemia, cytomegalovirus, they are the fetal causes. So why maternal diabetes leads to the development of polyhydramnios? Because in diabetes, that high sugar content in the amniotic fluid will increase the osmotic pressure. Similarly, hyperglycemia lead to fetal polyuria. That's the reason maternal diabetes lead to Fetal polyhydramnios is what you need to basically remember. Similarly, pregnancy-induced hypertension because of the edema of the placenta is also. And any cardiac, hepatic, or a renal dysfunction in the mother can predispose. So you call it as acute hydramnios, where there is a rapid accumulation of the liquor, and typically it occurs before 20th week. Chronic hydramnios is more gradual, and that can result in preterm labor, is what you should understand. So typically patients with polyhydramnios with increased fluid will have abdominal discomfort, pressure symptoms, Dr. Saab, hybat ho raha hai, so dyspnea, palpitation, indigestion, etc., etc. A very important clue for polyhydramnios clinically, the fundal height is disproportionately higher than the gestational age, is what you need to remember. Similarly, the uterus is tense. The fetal parts are felt with difficulty when you are doing dipping. You can elicit fluid thrill. And a malpresentation, non-engagement, whenever it is there, you should also look for whether there is any polyhydramnios. So, a ovarian cyst with pregnancy or ascites is the differential. So, how do you manage? High artificial rupture of membranes, termination of pregnancy. So, this will allow the gradual escape of the liquor. Gradual escape, so that the shock and separation of the placenta are avoided. And we use a Drew-Smith catheter. Drew-Smith catheter to rupture the hindwater is what you need to remember. And during pregnancy, you need to do termination of the pregnancy with the high artificial rupture of membranes if the fetus is dead or if it is malformed. But if the fetus is healthy and the mother presenting with polyhydramnios, you need to give rest, sedation, salt retention, treat underlying diabetes, toxoplasmosis, and termination of the pregnancy if the condition is not getting improved. That's what you need to appreciate. So when is a repeated amniocentesis is indicated? If there is a premature fetus with a marked pressure symptoms, indication for repeated amniocentesis. Please don't forget, that is the reason, this is the answer. Amniocentesis was the answer. How much fluid will you take it out? 1.5 to 2 liters can be aspirated, but you should not draw more rapidly than 500 ml per hour. Under the ultrasound control is what you should remember. So when there is a chronic hydramnios, how do you want to manage? So there is one thing before 20th week, rapid building of the amniotic fluid, that is acute hydramnios. The other is chronic hydramnios. If the patient presented during labor, if there is a malpresentation, cord presentation, cord prolapse, you need to look for them and they need to be managed. If the cervix is half dilated, then you can pass a Drew-Smith catheter. Once more, go back to the Google, YouTube, look how a Drew-Smith catheter looks like. It looks like a catheter, because that can be a prospective image-based question. And the active stage of the third stage is carried out. You need to do an active management, not a passive management, but active management. Otherwise, the patient will go into postpartum hemorrhage, because any polyhydramnios is distending and distension is a predisposing factor. Uterine distension is a predisposing factor for postpartum hemorrhage, is what you need to remember. So what are the complications of polyhydramnios? During pregnancy, there can be an abortion, preterm labor, pregnancy-induced hypertension, pressure symptoms, malpresentation. Anything can be the presenting feature. And during the labor, there can be a premature rupture of membranes, cord prolapse, abruptio placentae, shock, and postpartum hemorrhage. Similarly, what are the fetal complications of polyhydramnios? Prematurity, one of the favorite questions. Complication of polyhydramnios, please don't forget. And polyhydramnios can predispose to cord prolapse, placental separation, and that can lead to the development of asphyxia, is what you should remember. So I leave to you in the literature, doctor, favorite question of the examiner. Exam hall में मुरली भारद्वाज आपको याद आएगा. How do you manage chronic polyhydramnios? If there is no fetal abnormality, how do you manage? If there is a fetal abnormality, how do you manage? If there is no fetal abnormality, if there is a maternal distress, how do you manage? And if it is less than 37 weeks, what will you do? If the pregnancy is 38 plus weeks, what will you do? One MCQ invariably will be asked on this very important management algorithm, is what I want to underscore to all of you. I'm not going to read it for you. I leave these PowerPoint slides, everything in the onlinembbs.com, and please take an opportunity to subscribe to the live online coaching in 250 hours with Dr. Murali Bharadwaj. Daily live. It is not a video app, or I'm not throwing you some videos to finish. No. I'm going to be your classmate, your benchmate, your roommate, your table mate, and study along with you. Right? Now, the rate of turnover of amniotic fluid, punch your answers, doctor, everybody. Yes. So it's all revision. The revision of the concepts is all about energy, doctor. You need to have that energy and high levels of self-motivation that is required. If you look at the recent Ames paper, nothing, very easy paper, very standard questions, right? So if your preparation is good, if you are able to finish all 953 topics, if you spend 250 hours with Dr. Murali from June 1st to November 30, and once more, from December 1st to December 30, every day, we will have a full-scale grand test and discussion. Grand test and discussion. But up to November 30, if you subscribe to our program, this 250-hour program, then on every Sunday, you also get an access for a full-scale grand test and a discussion of the test on the Sunday only. Okay, so tomorrow is Sunday. So we have a test and there is a discussion. So what is the rate of turnover of amniotic fluid? It is about ½ liter per hour is what you need to remember. Maximum amount of amniotic fluid is seen at what time? How many weeks of gestation? Thank you, Manu. So I like to ask all of you a small feedback. You prefer 6 to 8 p.m. class, 7 to 9 p.m. every day, or 8 to 10 p.m. or 9 to 11 p.m. What is your preferred time, which is comfortable for all of you? Please let me know. Accordingly, we will schedule. For me, 6 to 8 is easy. In fact, for me, it's more easier if I deliver the class between 4 to 6 p.m. so that evening there are many things to attend. You tell me what is most comfortable time for all of you. I love to take an opportunity. First preference, second preference. What is your favorite time? 7 to 9 p.m. says Ram Sundaram. Burn is saying 4 to 6. Okay. So 6 to 8 according to Nasir. Very good. So probably I will in the Telegram group. I know that I hope that you're all there in our Telegram group. If you are not there, please call our helpline 900868 and get yourself included into our Telegram group. In the Telegram, I will give you one poll, and in the poll you can give what is the best time, right? Yeah. Any time, doctor, every day 2 hours you should study with Dr. Murli. Pakka, that is the deal. हम सब मिलेंगे, बैठेंगे, पढ़ाई करेंगे और नीट पीजी 2021 टॉपर बनने की ओर ट्रैवल करेंगे, right? So you have no reason to feel depressed. You have no reason to feel, oh my God, will I get it or not? No. I will not let you down in the next 6 months until the day of exam. We will study together every day. Deepanjali, Jennifer, I'm asking for 9 to 11. Okay. So, Surendra is a nocturnal traveler. So maximum amount of amniotic fluid is seen between 38 to 40 weeks. Amniotic fluid is maximum between 36 to 38 weeks. So this is such a frequently asked question. When do you see maximum amniotic fluid? So the amniotic fluid keep increasing until it reaches a peak by the time it is 38 weeks of gestation. And it will start decreasing from 38 weeks. So it is 800 ml at 40 weeks, 400 ml at 42 weeks, 300 ml by 43 weeks. So it keeps decreasing beyond the 38 weeks. At 20 weeks gestation, what is the amniotic fluid? 400 ml. Now what are the various causes of oligohydramnios? IUGR, post-maturity, maternal dehydration, any of them can lead to the development of oligohydramnios. Here's what you need to remember. Now, doctor, 10 points about oligohydramnios. So, reduction in amniotic fluid volume below 500 ml is called as oligohydramnios. So what is the etiology? 1, 2, 3, 4, 5, you should remember the causes. Placental insufficiency, preeclampsia, postpartum pregnancy, placental insufficiency. Urinary tract malformations like renal agenesis, obstruction of the urinary tract is responsible. So how does clinical picture will be? Polyhydramnios, the size of uterus is disproportionately large. Oligo, it is small for the date. The fetus is in a hyperflexed attitude and breech presentation is common in oligohydramnios. This is the favorite MCQ of examiner. What is the kind of presentation? Very common in oligohydramnios. If you do ultrasound, it shows a small amniotic fluid locules. And it is very important to exclude IUGR, identify the fetal presentation, And congenital anomalies, ultrasound is very useful in oligo. So what does oligohydramnios lead to? It leads to pulmonary hyperplasia, abnormal fetal development, abnormal presentation. So these are the important complications which you need to remember. So how do you manage if oligohydramnios is there? In the postpartum, if the pregnancy is postpartum, termination of the pregnancy is indicated. During the labor, observe for the fetal distress because it's very common. And if it occurs, do immediate vaginal or abdominal delivery depending upon the situation. So that is the story of management of oligohydramnios. So please tell your classmates that every day we have Dr. Murli Bharadwaj studying along with us like an exam going student, and he holds our hand to go and become a topper. So tell your friends that always our students are our best brand ambassadors. I'm giving you the link of our 250-hour program. So please populate it in your Facebook, WhatsApp groups, Telegram groups, wherever groups you are, and be our brand ambassador to tell the students to go to the onlinembbs.com to subscribe to this 250 hours program in the next 26 weeks with Dr. Murli Bharadwaj, covering all 19 subjects. So now, doctor, bacterial vaginosis. A 40-year-old woman presented profuse vaginal discharge. There was no discharge from the cervix on speculum examination. So how do you make a diagnosis of bacterial vaginosis? What are the important things in bacterial vaginosis? Clue cells, absence of lactobacilli, abundance of gram variable, not positive, not negative, variable cocobacilli is what you need to remember. So Amsel's criteria. Mia woman is asking, sir, can you tell tomorrow's gynecology topics? See, doctor, if you can go back to, I'll just show you. I'm trying to give an answer to Umar. Just bear with me. Yes. Yeah. So I like to tell you and show you that if you go to this top NEET PG 2021 FMGE in 250 hours live classes, every Monday to Saturday live online, preferably 6 to 8 p.m. But then June 1st to November 30. So we started June 1st to June 6th. First week is gynecology obstetrics. Second week, June 8 to 13 also gynops. 15 to 20 also gynops. You can reschedule your study schedule also in accordance with this. So then 2 weeks we will discuss surgery, 2 weeks SPM, then after that 1 week pediatrics and ad physio, biochem, etc., etc., etc. Right? And lastly, 4 weeks medicine in November. So the moment class is over, our people will process this video of our discussion. They'll also pick up my PPT, PowerPoint, and make it available. For example, June 1st to 6th, in the first week of June, we discuss ovarian cancer, medical disorders in pregnancy, ectopic pregnancy, and all these topics are over. Now, June 8th to 13th, Till the last class, we were discussing obstructed labor. Then after this class is over, latest by tomorrow, they will upload these videos also. Then once more, June 15, day after tomorrow onwards, every day we keep discussing. So if you go down, you have the upcoming weeks are all available and the lesson plan, and into that, after this broadcast, the video become included. So Kelte, next 26 weeks, you have energy, high energy, low energy, no energy, yes energy. At least you will find, oh my God, all my classmates across country, Yugender Bobby, Tahira Rafiq, Deepanjali, Surendra, everybody came to class and they're all finishing. Let me also finish. That is the team spirit. The whole purpose of studying together is that team spirit. Okay, so don't worry. We will start a good habit of studying every day in order to crack the exam. Any topper you take, doctors, any topper you ask in the entrance exam, they tell only one thing: Rose padho yaar, high yield topics padho, pura AIMS, PGI, All India और जिपमर, FMGE क्वेश्चन बैंक खत्म करो. सब लोग बोलते हैं मगर हम वो प्रैक्टिस करना, preaching is easier, practice is difficult. So that is the reason my intention is, if I also study with you like an exam going student every day, automatically you get a motivation, and excellence is not a happening, it is a habit. It is a habit every day. So that brings you over a period of time, just like walking, jogging, playing. Your body cannot accept unless you finish at least a couple of hours of preparation. The moment I take you to that state of addiction, done. You know very well how to do the cycling. The job of Dr. Murli is only to hold the back of your cycle until you get that the balance. Then you will start cycling to become the topper. Right, doctor? So that's the reason. Mark the day and every day join for 2 hours of discussion live with Dr. Murli, and also do the revision of these topics. AMSEL's criteria, what are they? Vaginal pH more than 4.5, more than 20% per high power field of clue cells on the wet mount, positive amine or whiff test, and homogeneous non-viscous milky white discharge adherent to the vaginal walls. They are the AMSEL's criteria, one of the favorite questions of the examiner. So how do you treat bacterial vaginosis? Metronidazole 500 milligrams orally, BD, for 7 days. Clindamycin vaginal cream 2%, one full applicator 5 grams intravaginally each night for 7 days. Metronidazole gel also is available. So metronidazole, clindamycin. Metronidazole, clindamycin. These are the 2 drugs that you need to remember. A creamy, fishy odor is characteristically. Where do you see it, doc? You see it in Gardnerella. Gardnerella. Once more, I want to tell all of you, you are able to see incus.live. This is another beautiful phenomenon. Incus.live is our platform where we are now placing 30,000 MCQs subject-wise, like similar to Facebook posts, question with answer, question with answer. Even on mobile, you can be able to go through them. Subject-wise, 30,000 MCQs are placed freely. Take opportunity to freely register into incus.live and go to the groups. In the groups, you find anatomy, physiology, biochemistry and all. You click on, right now I think physiology is done. Every day 2-3 subjects are uploaded. So around each subject 1000 to 1500 MCQs. You need not go anywhere for that WhatsApp group, this Telegram group. इधर उधर ढूंढने का जरूरत नहीं है. आपको पूरा 30,000 questions are available. You can start adding your points. You can add some good images, some good explanations, some good YouTube links, everything. So it is like Facebook for only PG entrance preparation or medical education, you can say. It is similar to that. Incus.live. Today only take opportunity to join into Incus.live, go to the groups, subscribe into the each subject-wise group and start debating on the questions. So that is another gift to all of you. Now, doctor, trichomoniasis. The discharge is pale green, watery, sometimes frothy. And why it's called strawberry cervix? Typically, there will be multiple petechiae on the vagina and cervical area, which is called strawberry cervix. And when you microscopically examine, how does trichomonas look like? Motile, pear-shaped, flagellated protozoa. It confirms the diagnosis. And vaginal pH, trichomoniasis more than 5.5. Please don't forget, favorite question. And the whiff amine test, it gives fishy odor. So how do you treat trichomoniasis? One of the favorite question of the examiner. Typically, treat the patient, treat the partner with oral metronidazole. Whereas vaginal gel metronidazole or vaginal douching with metronidazole, they are not efficacious. And if the woman is breastfeeding, you have given metronidazole, then you should discard the breast milk for the first 24 hours. One of the important points you need to remember about a breastfeeding mom taking metronidazole. So these are 5 to 6 cash boost points about trichomoniasis, doctor. Be very sure. Clue cells or bacterial vaginosis. हाँ, ये इमेज बेस्ड MCQ बनेगा कल के एग्जाम में. आप रिकॉग्नाइज करना चाहिए. So what are we going to do? In the incus.live, we are going to give you around 10,000 MCQs as image-based MCQ challenge. Image-based MCQ challenge. Okay, so take every opportunity to be part of Incus.live. Go to the group. You also contribute some handwritten notes, etc., and upload it into it. Okay, and you can also find a lot of entrance preparing friends. Send a friend request, become a friend with them on the Incus.live. Right now, there are 4 clue cells visible on the microscopic examination. The vaginal skin cells, which are coated with the bacteria. History of yellow-green watery discharge with pruritus. Gotcha. This is an important clue. Pruritus. Yellow-green watery, not candid. Even candidiasis patients also, oh my God, so much pruritus, doctor, do something. They'll be crying. While walking into the OP only, they come with that pruritus. But if it is a white cardi discharge, that is candida. Otherwise, yellow-green watery discharge hota hai trichomonas vaginalis. How do you treat trichomonas vaginalis? Metronidazole. Clue cells, bacterial vaginosis. Now, what do you see in normal vagina? Trichomonas vaginalis is a part of the normal vaginal flora is what you need to remember. The patient has discharge per urethrum and microscopy shows the presence of Gram-negative bacilli. What is the most probable diagnosis? Gonorrhea. Gonorrhea is what you need to remember. Now comes the next favorite topic of the examiner, carcinoma endometrium. At least 5 to 10 points you have to become master. So what are the various hormone-dependent carcinomas? Prostate carcinoma dependent on testosterone, endometrial carcinoma on the estrogen, breast carcinoma also on estrogen, not ovarian cancer. Carcinoma endometrial. Abhi aa gaya, painful question. Positive superficial inguinal lymph node status. How do you like to classify? Doctor, tomorrow afternoon 3 p.m. we have the every Sunday full-scale grand test discussion. Okay? Every Sunday full-scale grand test discussion. NEET PG. Please don't forget. And please call our helpline 9000-868-356 and subscribe to the online MBBS 65 full-scale grand test program. Right? So every Sunday we will have a grand test or maze mein discussion karenge. Every Sunday you should improve. You should know where you are going, good and bad. Nia Umar, thank you. Amazing, sir. Thank you a lot. Every student performs, improves because of you. Like a magic key to success. Simple thing, doctor. A good doctor, bad doctor. Good resident, bad resident. फर्क इतना ही रहता. क्या फर्क है? You know who is a good resident while you are doing MD? Who is a good resident? Who is a bad resident? A good resident runs around, collects the investigation reports and be ready by the time the rounds start. So what are the investigations? Fat, LFT, everything. By heart he remembers and tells. He's a great resident. Not necessarily the most knowledgeable. And who will run for investigations because he has inside his belly a feeling that, oh my God, this is going to be lymphoma or TB or Kikuchi disease. What is it going to be? That enthusiasm is everything about life, doctor. Right? Similarly, good doctor, bad doctor, not big difference in knowledge levels. A good doctor listens. By listening only, he knows what is your diagnosis, what is possible 1, 2, 3 diagnosis. So the one who listens the most is like revising Harrison's internal medicine. From that you get a lot of clues. What is the underlying cause of the patient's illness? Very chota farak rehta hai. A bad doctor writes prescription and throws it on the table, that's all. But a good doctor explains every medicine, how does it work? Now what are the choices available in the treatment? And which choice is he offering to you as a patient? And why he is offering the choice? Why he added the diuretic? Right? So, the moment you explain, you are a great doctor. अरे हमारे डॉक्टर साहब कितना बताया हमको, ओ दिल में रख के पूजा करेगा पेशेंट. Similarly, the difference between a good student, bad student, इतना बड़ा फर्क नहीं रहता, इतना रहता. The one who studies every day, the one who has a focus on 953 topics, the one who takes at least 1 to 2 hours to have a group of classmates and discuss with them, you are the best student. You take any NEET PG topper, he tells the same story. And the difference between a good teacher and bad teacher, every teacher loves the student, but good teacher, bad teacher. The good teacher is the one who sits like a student with all his students and studies like a student along with them as such he is exam going. That teacher is a good teacher. He's a great teacher, right? So always remember, good and bad, the difference is very trivial. So doctor, let us be good students, good aspirants, and emulate those traits that made the people to become the toppers in entrance exam. So doctor, superficial inguinal lymph nodes positive. What is the carcinoma endometrium stage? Typically 4D. So you should know everything, anything about this story, doctor. Very important classification. Stage 1A involves endometrium. Stage 1B involves myometrium. Stage 2 involves cervix. Stage 3A involves ovary. 3B means it involves vagina. 3C means it involves lymph nodes. And 4A means it involves bladder and bowel. 4B means there are distant metastases which are occurring. Stage 4B. So, Abhishek Pandey is asking, can I watch previous lecture of the gynae from the June 1st? From the June 1st. Jennifer, I like to tell you simple point. Okay, I agree your point, Jennifer. Sir, if you can give, good to see Shivam Panchal. So, Jennifer point is right. कल डिस्कस करने वाला टॉपिक आज बताए तो हम पढ़ के आएंगे, क्यों नहीं करेंगे? We will do that. What you all guys do is join incus.live. Okay, incus.live में join हो जाना. अगर हो गया तो what I will do is, in that I will start one group called 250 hours to become topper with Dr. Murli Bharadwaj sir. So I will ask our people, what are the 60 to 70 MCQs we are going to discuss tomorrow, to post them questions without answers. Okay, so you solve the questions before you come to the class, so that way it become interesting. Okay, so first what you need to do is you go and subscribe freely in the incus.live. Okay, then one more question is, Vani is asking, sir, I have subscribed for online MBBS. Will I have access to Incus? See, in Incus, we have a program with different teachers. I'm a free guy, but different teachers, they expect to be paid, right? So that is the reason, whatever the different teachers, they deliver the lectures, they're live streamed into our YouTube channel of online MBBS. So they are the Incus teachers. You need to subscribe for individual teachers program. For example, Dr. Ravi Kiran is teaching you orthopedics, excellent teacher. If you want to get the Ravi Kiran's 40 hours revision of 1000 MCQs discussion in orthopedics, in the Incus we create a course where we archive all the video lectures of Dr. Ravi Kiran. Please subscribe. It's a small price, about 2000 rupees. You get that 40-hour session of Dr. Ravi Kiran. Okay, but this 250-hour program which I am talking, it is there on the onlinembbs.com only as a special program, live online session of this year, right? So please take a chance to subscribe, maybe for a throwaway price, and support us also, because there are a lot of employees who work to make the production happen. So it's a real difficult time to sustain an organization. So that is the reason, but we have a passion to teach. What can we do? Without teaching, we cannot live. So that is the reason I always say, Subscribe even for a small price into the onlinembbs.com video library, full-scale grant test, question scanner, everything, and enjoy the program, right? Along with the PowerPoints, notes, everything. So, doctor, stage 1A endometrium, 1B is myometrium, ovary 3A, vagina 3B, lymph node 3C, bladder and bowel is 4A, stage 4B is the liver, distant metastasis is what you need to remember. So I leave the literature for you, doctor. Please don't forget, this is a very important endometrial carcinoma staging. Definitely पूछने वाला question है. Now, doctor, long-term tamoxifen therapy, what does it lead to? Long-term tamoxifen therapy, tamoxifen is a selective estrogen receptor modulator. So that is the reason it has got a antagonistic effect some places and agonistic, estrogen agonistic effect on the endometrium. That's the reason it predisposes to endometrial carcinoma is what you need to remember. Once more, favorite question. The stage of the carcinoma endometrium when the invasion is 10 millimeters is 1B. So as I told you, this is most important. More than 50% invasion of myometrium is 1B. Less than 5% invasion of myometrium is 1A is what you need to remember. Now all this will predispose to endometrial carcinoma, except you should remember radiation, tamoxifen therapy, unopposed estrogen, they're all predisposing. But oral contraceptive is anti to the estrogen. So that is the reason it won't predispose. So Fatafat Polar Doctor, the list of risk factors for the endometrial carcinoma. You should remember that postmenopause, atypical hyperplasia of endometrium, nulliparity, early puberty, late menopause, treatment of unopposed estrogen, tamoxifen therapy, obesity, hypertension, diabetes, and also breast cancer, colon cancer, ovarian cancer, breast cancer, colon cancer, ovarian cancer, they are also associated with endometrial cancer is what you need to remember. Now, doctor, the risk factors for the development of endometrial carcinoma, what are they? Obesity, family history, hormone replacement therapy, late menopause, early puberty, that increases the estrogen exposure. So what is the choice of adjuvant treatment of the endometrial carcinoma stage 1A, grade 1? Once more, doctor. High yield topic. Hit. Sure shot आने वाला क्वेश्चन है. कल के FMGE NEET PG लिखते हुए आपको मुरली भरद्वाज जरूर याद आएगा. Because the same question ditto will come. Acha, Jordan Williams, good to see. So this is the question in Ames, June 2027. Very good. So doctor, remember, what are the choices of treatment? Surgery, radiotherapy, chemotherapy, hormonal therapy. So whenever endometrial carcinoma patient is there before you, you need to do the risk stratification for the adjuvant therapy. Accordingly, you divide the patients into low risk, intermediate risk, and high risk. So G1, G2, grade 1, grade 2 without myo-invasion, without invasion of the myometrium. No cervical involvement, no ischemic involvement, negative peritoneal cytology, no lymphovascular space invasion, no evidence of mets and tumor less than 2 will make it low risk and no further treatment is required. Follow, that's all. Intermediate risk, there are some parameters. Brachytherapy should be given. High risk, grade 3 tumors, 1B tumors, head neck cell spread, cervical invasion, lymph node mets, lymphovascular space invasion. Then you have to do extended beam radiotherapy is what you need to remember. Very good. Surendra, thanks for acknowledgement. So our guys are now posting incus.live is our Facebook thing. So you also can write some handwritten notes, take a snap, post it. Take a snap, post it. You can start, you can post it in already existing group or you can start a group. Anything is okay. And you can let other members to join your group. You can tell your friends, hey, I started a group, man. You all guys come and join my group. So you can make it open for the other group members, or you can permit only selective people to join your group. Everything, your choice. So incus.live is like a Facebook for exam preparation, any exam preparation, basically. It's a originally Facebook by Mark Zuckerberg was started. The idea is to connect the people in the campus. After that, the connections became more romantic connections. After that, personal life intrusion. Now Facebook is gigantic. So I want to create a similar social network in education. Those who prepare for USMLE, MBBS exams, then even dance classes, music classes, cooking classes, anything, we are now letting people to join for the academic ideas, handwritten notes, upload it, so that it become available for the generations of the students. So that's the plan. Now, doctor, surgery is the main modality of treatment in carcinoma endometrium. So what will you do? Total abdominal hysterectomy with bilateral salpingo-oophorectomy without extended surgical staging, followed by post-operative radiotherapy. So surgery is the main modality of treatment in carcinoma endometrium. Extensive surgical staging, excision or biopsy of any enlarged or suspicious pelvic paraortic lymph nodes is all being carried out. And if there is no nodal involvement, all the nodal tissues should be removed from over the distal vena cava, below the inferior mesenteric artery, between aorta and the left ureter, from the inferior mesenteric artery to mid left common carotid artery. So early stage endometrial cancer. Early stage endometrial cancer. Stage 1A, stage 1B. You do total abdominal hysterectomy, bilateral salpingo-oophorectomy alone if there is no lymphovascular space involvement. Then you need to do vaginal brachytherapy, intravaginal brachytherapy along with TAH and BSO if the lymphovascular space invasion is present. Similarly, stage 1A, grade 3, you will do extensive surgical staging done along with total abdominal hysterectomy, bilateral salpingo-oophorectomy with the intravaginal brachytherapy. So please don't forget these treatment recommendations. Doctor examiner is going to play with you. Stage 1A, stage 1B, जरा बट्टी मारने वाला चीज है मगर मारना ही पड़ेगा. Now radiotherapy, you will give both pre-op and post-op. But nowadays, in the era of extensive surgical staging, preoperative radiation is less commonly done. But still, if a patient is having a gross involvement of cervix or vagina, then it will be required. Pre-operate irradiation. Now, doctor, yes, I leave the literature for you. Then coming to the chemotherapy, what are the common agents in endometrial carcinoma? One of the favorite MCQ. Cyclophosphamides, anthracyclines, platinum, cisplatin, and taxanes. Now, carcinoma endometrium with the involvement of vaginal wall. Come on. Now you should answer this question correctly. Who is going to give me the correct answer? Question number 478. We already finished discussing 478 MCQs. Another 5 days we discuss almost another 300 questions. The 700, 750 questions is more than enough for you, gynecology obstetrics doctor. Everything else is only a little namakam, chamakam on this story only, on these high-yield topics, right? Very good. So, Jennifer and everybody is betting on B, 3B. Absolutely. Very good. See, now, Jennifer, what will you do? You have to have that 100 pages notebook. In that, you need to write endometrial carcinoma is a high-yield topic. In that, staging is a batti marne wala topic list mein chale jana. It is a part of your hit list, HYT list. Okay? And not only that, go to incus.live and Jennifer, you write down on the paper and then post, take a snap and post some good points that you understood in this today's class. In the incus.live as one post. And tell your friends, hey man, I'm enjoying a class every day, free YouTube class, and ask your friends also to join you. Okay, so that's the plan. So Dr. Incus.live, I want to see all of you subscribing freely. Now, carcinoma endometrium with vaginal wall involvement. So as I told you once more, vagina is 3B. Lymph node is 3C, ovary is 3A, bladder and bowel is 4A, liver is 4B. This picture, इधर बैठ जाना कल के एग्जाम के लिए. समझ में आ गया ना? Very good. Now, colposcopy. So, doctor, 35-year-old female P3 plus 0 is observed to have CIN grade 3 on colposcopic biopsy. What would be the best initial management? One of the favorite questions of the examiner is colposcopy because हम इस देश में जी रहे हैं जिस देश में बहुत carcinoma cervix is a very big problem. That's the reason. Okay, now LEAP is considered to be the best way to manage the CIN grade 3. So you should remember CIN2, CIN3. All CIN2 and CIN3 require treatment. Why? Why all CIN2 require treatment? Because they did a meta-analysis of a lot of observational studies. And they came to the conclusion that CIN2 will progress to the carcinoma in situ in 20% cases and to invasion in 5%. That's what you need to remember. So the preference of CIN2, CIN3 is LEAP. What do you do in LEAP? It will allow a specimen to be sent for evaluation to enable the pathologist to identify any occult micro-invasive cancer in the adenomatous lesions to ensure that these lesions are adequately treated. So CIN3, how will you identify CIN3, doc? Severe dysplasia. severe nuclear abnormality in the immature basal cells. Keratinization, cornification is present on the surface. And how does it appear on the colposcopy? Acetowhite reaction. So a dull, dense, white, not shiny remains for longer time, and the surface contour is raised. Margins are distinct, and there may be coarse punctuation or mosaic appearance, and it rejects iodine. So a dense opaque acetowhite area with coarse mosaics, you call it as CIN3 on colposcopy. Once more, this is going to be one of the favorite question of the examiner, right? One of the favorite questions of the examiner, image based. You should be very sure. Loop electrosurgical excision procedure. So basically, you will be removing abnormal cells from the surface of the cervix using a thin wire loop that acts like a scalpel. And a painless electrical current passes through that loop and it cuts the thin layer of the surface cells. That is LEAP. Loop electrosurgical excision procedure. CIN2, CIN3, CIN2, CIN3. That's what you need to remember. Now, doctor, intrauterine adhesions. How will you see? So basically, hysteroscopy, you are entering guha inside the uterus. Intrauterine adhesions. How much magnification with colposcopy? 10 to 20 times. So colposcopy is that binocular stereoscope, and that gives you 10 to 20 times abnormal, 10 to 20 times magnification. So what is the best way to look at endometrial cavity? Always biopsy is the Supreme Court judgment. LEAP stands for Loop Electrosurgical Excision Procedure. The areas of dysplasia in colposcopy, how do you identify that? 3 to 5% acetic acid is helpful. So you find geographic satellite lesions after the application of 5% acetic acid far away from the squamo-columnar junction. That's the reason this is an example of a low-grade lesion, right? So this is how acetowhite reaction. Once more, what is adequate colposcopy? Inadequate colposcopy, you should be very sure. So what is the meaning of satisfactory colposcopy? If you are able to see the entire transformation zone, then it is called satisfactory colposcopy. So adequate visualization, entire squamo-columnar junction, proximal and distal end of the lesion, both the things if you are able to see, that is called satisfactory colposcopy is what you need to remember. 45-year-old female with postcoital bleeding, visible cervical mass on speculum. What is the next step to investigate? Colposcopy is the next step to investigate her. So now tell me, doctor, one of the favorite list of things you need to remember. Indications of colposcopy. Definitely puchega examiner. Very simple. Why do you want to see somebody's cervix? When you have done pepinical log smear, cervical cytology, if there are epithelial cell abnormalities. Similarly, if there is a HPV DNA of the high risk variety, 16, 18, any suspicious cervical lesion, vulvar or vaginal neoplasia, history of intrauterine diethylstilbestrol exposure, sexual partner of the patient with genital neoplasia. That is HPV. This is also HPV. Oncogenic HPV, unexplained vaginal bleeding, postcoital bleeding, and any positive screening test on cervicography or speculoscopy. indications for colposcopy ab bhulna nahi. The next topic is endometrial hyperplasia. What is the ideal treatment for a 55-year-old female who has a simple hyperplasia of the endometrium with atypia? So endometrial hyperplasia is being divided into with atypia, without atypia, simple endometrial hyperplasia. Accordingly, you should know how do you clinically manage. Simple hysterectomy is considered to be the treatment. So, doctor, 10 points about endometrial hyperplasia. Endometrial hyperplasia. Increased proliferation of the endometrial glands compared to stroma. So that the gland to stroma ratio compared to normal proliferative endometrium, it has increased. So what are the risk factors for the endometrial hyperplasia? Already we discussed what are the risk factors for endometrial cancer. Estrogen replacement, PCOD, estrogen producing tumor like granulosa cell tumor, perimenopausal, menopausal period, any excessive cortical function, obesity, diabetes, they're all considered to be the risk factors for endometrial hyperplasia. Like a parrot, you should rattle it out in the tomorrow's entrance exam. There are so many classifications, but very popular is simple hyperplasia without atypia, complex hyperplasia without atypia, and simple and complex with atypia. Simple hyperplasia without atypia, how does it look like? This is an image-based MCQ for the tomorrow's FMGE, AIMS and all exams. Simple hyperplasia without atypia, it is also called cystic or mid hyperplasia. Glands of various sizes, irregular shapes with cystic dilatation, that's what you find. Mild increase in gland stroma ratio, and they are unlikely to progress to adenocarcinoma. Mainly it indicates one point, persistent estrogen stimulation is there in this lady. That's the indication. Complex hyperplasia without atypia. In this, there's an increase in the number and the size of the endometrial glands. The glands remain confluent, remain distinct and non-confluent. 3% progression is there. This is the favorite MCQ. Kitna percentage complex hyperplasia without atypia will go into malignancy? आप पूछते ना मेरा रैंक कितना या मेरे कैटेगरी में कैसा MD आएगा, MD general medicine surgery, what do I get? Similarly, God is asking complex hyperplasia without atypia, what is the percentage of progression? 3%. Atypical hyperplasia. Typically, this is how you recognize histologically atypical hyperplasia. Atypical because nuclear membrane is thickened, prominent nucleoli, that makes it pre-neoplastic. So once more, please revise, doctor. Adenomatous, atypical, adenocarcinoma. Adenomatous means simple hyperplasia, atypical and adenocarcinoma. What are the differences histologically? Take a bar. Just have a look. So how do you manage? This is the most favorite question. How do you manage? Simple endometrial hyperplasia without atypia. If you give high dose progestogens with repeat histology after 3 months. Okay, clear? And how do you give that high dose progestogens? You will give levonorgestrel containing intrauterine system, Mirena. Mirena is something that you give. You can also give progesterone orally. Then surgical, transcervical resection of the endometrium, hysterectomy, especially if there is a atypical endometrial hyperplasia. So that is the reason whenever endometrial hyperplasia is there. So doctor, I will try to, yes. It is much better visible now. Yeah. Endometrial hyperplasia without atypia, with atypia. That's how you define. So conservatively, counseling, identify and address the risk factors, follow up with endometrial biopsy. If it regresses, what will you do? At least 2 consecutive biopsies, 6-month interval should show the proof that it has regressed. Then if 2 consecutive negative biopsies are there, will you say patient, hey, you're corona free, you can go home? No. If the high risk factors are there, like, what are the risk factors? Then long-term follow-up should be done, annual endometrial biopsy. That is the policy. समझ में आई है? मैं और एक बार बोल रहा हूँ. Endometrial hyperplasia without atypia on conservative management, if it regresses, proof of regress is 2 consecutive 6-month negative biopsies. But high risk, if it is there, you need to do long-term follow-up with annual follow-up. Suppose if it failed to regress symptomatic with adenomatous atypical cells, then you have to give progesterone. You can put Mirena, levonorgestrel IUS, or you can give continuous oral progesterone, medroxyprogesterone or norethistron you can give. Now with atypia, what is the option? You have to do total hysterectomy, total abdominal hysterectomy. Premenopausal, total hysterectomy, bilateral salpingo-oophorectomy plus or minus ovarian conservation. Postmenopausal, total hysterectomy plus bilateral salpingo-oophorectomy. So that is the important goal which you need to remember. Okay, doctor? So please take this important algorithm. This is a hit, high-yielding topic in the upcoming NEET PG exam. So the treatment of atypical endometrial hyperplasia is, ideal management is hysterectomy. If the hysterectomy is not viable, but it is not a viable option for young patients and patients with poor surgical candidate, so you have to give high dose continuous progestin therapy, typically 20 milligram medroxyprogesterone acetate. Another option is 40 to 160 milligram megestrol acetate daily for 6 months. And biopsy every 6 months because of the high risk of recurrence is considered to be the protocol. Snowdrop is asking, sir, is it possible to increase the size of the text? See, this PPT is all available in the onlinembps.com video library, doctor. आप खेलते रिवाइज कर सकते हैं. A 45-year-old postmenopausal woman presents with vaginal bleeding. Transvaginal ultrasound is showing an endometrial thickness of 8 millimeters. What is the next step? You have to send for histopathological examination of the curettage. So doctor, whenever postmenopausal bleeding is there, less than 4 mm, more than 4 mm, more than 4 millimeters, you have to go for endometrial sampling. Less than 4 millimeters, you need to look for risk factors. If there are risk factors, even if it is less than 4 millimeters in postmenopausal bleeding, that becomes an indication for endometrial sampling. Simple common sense, right? Now, endometrial biopsy, when will you do? Very interesting question. Just before menstruation. So typically, proliferative phase, before ovulation, secretory phase, after ovulation, and finally menstrual phase. Just before menstruation, you need to do endometrial biopsy. So this is the most important MCQ in the tomorrow's entrance, doctor. Definitely. एक MCQ नहीं आए तो मेरा नाम मुरली भरद्वाज नहीं. Radiological investigation in a young reproductive age woman, what is the ideal timing? First 10 days of menstrual cycle. Unlikely that she will be pregnant. Tubal patency test, histosalpingography, what is the best time? 10th day of menstrual cycle, that is pre-ovulatory phase. Fern test. Obviously, in Fern test, you are trying to look for the effect of the estrogen on the endometrium, so pre-ovulatory phase. Postcoital test. Typically on expected day of ovulation, postcoital test. Endometrial biopsy, 23rd to 26th day, just before menstruation, premenstrual phase. So, this ideal timing is a favorite topic of the examiner. The age of metropathia hemorrhagica. What is the common typical age of the patient? It is 40 to 45 years. What is the other name of metropathia hemorrhagica? Scroider's disease. It is typically seen in the women 40 to 50, not related to parity. 6 to 8 weeks amenorrhea followed by menorrhagia, which is painless. Painless menorrhagia. This is a favorite MCQ clinical vignette. Uterus is bulky because of myohyperplasia and cystoglandular hyperplasia. Swiss cheese. Swiss cheese pattern. Kal jarur puchega examiner. Metropathia hemorrhagica. And it can be associated with follicular cyst of the ovary. All because of that excess estrogen effects. So what is the treatment of simple hyperplasia of endometrium? Progesterone. Right? What are the things associated with endometrial hyperplasia? If you give hormone replacement therapy, unopposed estrogen you are giving. Glucose intolerance, PCOD, they are all associated. Swiss cheese pattern, where do you see? Metropathia hemorrhagica. Metropathia hemorrhagica. So this is called the Swiss cheese appearance of the endometrium. Swiss cheese. Swiss cheese क्या होता है? राधे श्याम, गोपी कृष्णा, कन्हैया क्या खाएगा? चीज खाएगा, मक्खन खाएगा. तो ये कृष्ण भगवान खाने वाले मक्खन और स्विट्जरलैंड में मिलने वाले मक्खन के बीच में फर्क क्या होता है? स्विट्जरलैंड के मक्खन में होल्स होता है. Holes, right? So that is called Swiss cheese pattern. So now, doctor, pelvic types is the next favorite topic of the examiner. What is the condition associated with lack of single pelvic ella? Single pelvic ella is called Nagli's pelvis. So this is a osteomalacic pelvis, Robert's pelvis, scoliotic pelvis, coxalgic pelvis, split pelvis, necklace pelvis. So Robert pelvis, both ala of the sacrum are absent. Then rachitic pelvis is flat. There is softening of bone, decreased epidiameter of the inlet, then increased epidiameter of the outlet. They are the features of rachitic pelvis. Triradiate pelvis is the name for osteomalacia में जो pelvis होता है वो होता है triradiate pelvis. So what is the smallest diameter of the true pelvis? Interspinous diameter. बाबू ये diameters को बट्टी मारने वाले लिस्ट में ऐड करो. Interspinous diameter is how much? 10.5 centimeters is the smallest. So doctor, remember, one of the favorite questions of the examiner is true conjugate, obstetric conjugate, diagonal conjugate. So this is true conjugate. See, the common point is sacral promontory. But in the pubic bone में upper part, middle part, lower part, upper part, middle part, lower part से आप draw कर रहे हैं. If the landing is into the upper part of the pubic bone, वो होता है true conjugate. Then middle होता है obstetric conjugate, and diagonal conjugate is the one which is hitting the lower one. So that is the reason it is longest. So you can remember toddy. Toddy pite na? Toddy, you drink toddy kind. So TOD. Uppermost is true, middle is obstetric, and lowest is diagonal, which is hitting the pubic bone. That's the point you need to appreciate. I think this joint video library is coming in the middle of all of you. 1 minute. Yes. So we are talking about this, doctor. Pubic bone, if you take upper part of it, middle part of it, lower part of it. Uppermost part of it होता है true conjugate 11 centimeters. Middle is obstetric, and diagonal is lowest, is what you need to remember. Similarly, biparatal diameter, please don't forget, लिख लो, book में लिख लो, बट्टी मारो, दिमाग में रखो. Definitely एक क्वेश्चन आएगा एग्जाम में. अगर ये मंत्र मालूम नहीं है तो ईश्वर भी हेल्प नहीं कर पाएगा. So bitemporal diameter is 8 centimeters. So biparatal diameter is 9.5 centimeters. 9.5 centimeters. Bitemporal is 8.5 centimeters. Bimastoid, right? 7.5. Supra and subparietal asynclitic head transverse diameter is 8.25 to 9 centimeters. Then one more. Batti marne wala cheese. So you should know suboccipitobregmatic, suboccipitofrontal, occipitofrontal, right? This is occipitofrontal, mentovertical. This is mentum, chin, mentovertical, submentobregmatic, this is mentum के पीछे होता है submentum से bregma, submentobregmatic, submentovertical. Wow, I used to hate this subject of fetal skull. maternal pelvis. Amma. Half your adrenaline is gone by the time you read this. To overcome the drudgery, if life is becoming lethargic reading Datta and Shaw, open Harrison and take one hot topic like renal tubular acidosis, pura, all the drudgery used to go away, right? But all subjects, same passion, same love, you should study, doctor. Then only you can make it. So suboccipitobregmatic is 9.5 centimeters flexed vertex. Suboccipitofrontal 10.5 centimeters partially deflexed. Occipitofrontal is 11.5 deflexed vertex. Mentovertical बहुत लंबा है ना, इधर से शुरू करके इधर तक, इधर से उधर तक. Mentovertical longest 14 centimeters. Submentobregmatic 9.5 centimeters in face presentation. Submentovertical is 11.5. So this is one table, doctor. If you like it or don't like it, you have to remember it, mug it, digest it, assimilate it, put a subcutaneous chip of these values, but crack it in the tomorrow's exam. So do you think some super duper knowledge will make you topper? No. Fevicol लगाना, बैठ जाना, जो बट्टी मारना मारना, मुरली भरद्वाज के साथ. ठीक है? So that is very, very important, doctor. Now, maximum diameter that pass through the maternal pelvis, it is occipitofrontal. Occipitofrontal. So suboccipitobregmatic 9.5, biparietal 9.5, suboccipitofrontal 10, occipitofrontal 11. That's the reason of all these four measures. 11 is occipitofrontal, which is longest. Biparietal diameter is 9.5. So, will you promise me that you will make every point to write in your 100-page notebook that you are going to मुझे वादा करोगे कि ये values को दिल लगा के याद रखना और 10 classmates in reading room. Oh, nowadays reading rooms are not there, right? So at least join incus.live community, and you find a lot of PG entrance preparing students. You can become friends, and also you can post questions, answer questions in the post. Which pelvis deep transverse arrest होता है? Android pelvis. Android pelvis. Direct occipito-posterior position is a favorable position in anthropoid pelvis. So, occipito-posterior position is an abnormal position of the vertex. 10% of labors. So, there are various ways by which, like a kung fu karate of Shaolin, the fetus will be rotating to come out. One of the steps is internal rotation. If that doesn't happen, then that leads to persistent occipito-posterior position. It occurs in 5% of births. Right occipito-posterior is more common than the left occipito-posterior, favorite MCQ of examiner. So, what is the pelvic diameter estimated by palpating fingers? So, typically, you'll be palpating interspinous diameter. Incus, very good. Thank you, Jennifer Selvarani, for joining Incus. Also, tell your other classmates to join Incus.live and go to the groups. In that, you can also start a group. You can write handwritten notes, post it, and then see playing with a lot of 30,000 questions we are uploading into Incus.live. Now, doctor, interspinous diameter. The length of diagonal conjugate. कल examiner ये image based MCQ देगा, जरूर देगा, and he will ask, hey man, what is this diameter that you are checking? That is the diagonal conjugate. Is the solid line, solid colored line, and blue line is the true conjugate, and the obstetric conjugate. So you should remember, toward uppermost is true conjugate, middle is obstetrics, down is diagonal. So this is how interspinous diameter is spelled. Intertuberous diameter, if you want to check. What do you use, doctor? Thorne's pelvimeter. Thorne's pelvimeter is the one which you will use for intertuberous diameter, is what you need to remember. And if you want to estimate the subpubic angle, how will you do? Using both the thumbs, examiner actually traces descending rami down to the tuberosities and calculates the subpubic arch angle. Similarly, what is frank beach? Typically, lie is longitudinal or vertical, presentation is breech, presenting part is sacrum, and attitude is flexion, except for the legs at knees. Knees are like, it's like that Olympic athletes jumping into water, right? So that is frank breech. This is single footling, complete breech, and shoulder presentation. So examiner, abnormal presentations is a high yield topic sitting in Parampita Paramatta examiner के क्वेश्चन बैंक में बैठा हुआ है. Now identify the diameter which is being labeled B. So where is B touching, doctor? See, most important. So B is touching uppermost part. B is touching uppermost part. C is touching middle part. D is touching lowest part. Toddy, you have to remember toddy. True conjugate on the topmost point, obstetrical conjugate in the middle way, diagonal is the bottom. So Todd. Darupio, toddy is that. Persistent occipital-posterior position. It is most common in which pelvis? Android pelvis is what you need to remember. Very good, doctor. We reached 100 minutes of broadcast, 1.5 hours. 5 minutes, let us give vocal rest. I'm not yet over. I'm going to hit another 30 questions before I say मुझे अलविदा ना कहना. So this is only intermission. शोले मूवी में आप गब्बर को देख रहे हैं. गब्बर ने बोला, अरे ओ सुपर के बच्चे यार, कितने एमसीक्यूज बाकी है सरदार, 30 more questions बाकी है. अच्छा, ठीक है. So we'll take a 5 minutes intermission. Please stay online. I will take a little glass of water. You also go into kitchen. Take a short break, and then we'll finish remaining 30 questions. That is 100 questions we have finished today, right? That satisfaction should come. 5 minutes. So, welcome back everybody. Let us continue our journey in 250 hours in 26 weeks with Dr. Murali Bharadwaj. Now, doctor, pelvic inflammatory disease, least common with, obviously, condom is a preventive factor. Primary peritonitis, why it is more common in females? Because the ostia of the fallopian tubes, they communicate with the abdominal cavity. That's the reason there's a great chance of primary peritonitis and ascending infection. A 25-year-old patient presents with vaginal discharge. Examination reveals chlamydial infection. So how do you treat chlamydia is the important question. Azithromycin plus contact tracing is important. So if you look at the three popular notorious sexually transmitted infections, chlamydia, azithromycin 1 gram per orally once, or doxycycline 100 milligram per orally BID for 7 days. Gonorrhea, ceftriaxone 250 milligram IM plus azithromycin 1 gram per orally once. Trichomoniasis, metronidazole, tinidazole are the ones which are used as a treatment, is what you need to remember. Chlamydia trachomatis. Guys, after this session is over, tomorrow morning, Gudtehi, 9 to 12 AM, you finish full-scale grand test. So where do you get this full-scale grand test? If you go to onlinembbs.com, the test engine of it is called nextneetpg.com. nextneetpg.com. On that we have the 65 full-scale grand test, every Sunday grand test available. So please take a chance to do the revision. Afternoon, 3 o'clock, Dr. Murali will be there with you to discuss the question paper. Right? Now, OCP, using OCP is associated with increased risk of asymptomatic chlamydial infection. So, condom prevents but OCP promotes. So, doxycycline 100 milligram BD, 7 days. First line, but it is contraindicated in pregnancy, particularly beyond 11 weeks. Or azithromycin 1 gram stacked, followed by 5 milligram once a day for 2 days. 1 hour before or 2 hours after food, very important. And single dose azithromycin is no more recommended for the management, is what you need to remember. Feeds Hugh Cotis, where do you see? Gonorrhea. So intraperitoneal structures are involved by the pelvic inflammatory disease. Intraperitoneal exudates will cause that violin string adhesions between the liver capsule and the peritoneum, and the perihepatitis that you see is basically called Fitz-Hugh-Curtis syndrome, is what you need to remember. Acute pelvic inflammatory disease, what is the most common route? Ascending infection. How do you evaluate? PID. Laparoscopy is the best way to evaluate. In PID, due to the Neisseria gonorrhea, the tubal damage is because of what? Because of the endotubal damage, is what you need to understand. Abhi aa gaya? Ram aur Sham, twins. And next favorite high-yield topic of the examiner. Where do you advise vaginal delivery? In twins. First twin vertex, second twin breach. First twin vertex, second twin breech, almost 69 position. One is up, one is down. So vaginal delivery is recommended. So doctor, this is one favorite algorithm on which lot of questions are asked. First twin, second twin, both of them are vertex. Both of them are drooping down their heads and want to come down, vaginal delivery. First twin vertex, second twin non-vertex, but more than 1800 grams in weight. So vaginal delivery of A, and what will you do with the B? If the second twin is a non-vertex, that is, if it is breech or transverse with feet dependent, then vaginal delivery. But the second twin is transverse with the back dependent, then external version to vertex. If it fails, then you need to do cesarean. All these permutations of clinical situations will be created like an MCQ and given to you in the tomorrow's exam, doctor. Be very sure. First twin is vertex, second is more than 1800 grams and non-vertex position. No thinking, cesarean straight away. If the first twin is also breech, then cesarean, there is no other choice. Will you remember this? एक फुटबॉल ले लिया ना, कल के एग्जाम में जरूर पूछेगा. Vaginal delivery is allowed in which situation? First twin vertex, second twin breech. Yes, you can. First twin extended breech and second twin vertex. First twin mento-anterior, second breech. It is not allowed in monochorionic, monoamniotic twins. Then similarly, sir, what about internal podalic version for the transverse line? Yes, that is also an option which is available, but in the modern obstetrical practice, no one uses such a barbaric procedure of internal podalic version anymore. Now, about multiple pregnancies, what is true? Twin peak sign is a sign of dichorionicity. One of the favorite questions. So twin peak sign ko kehte hain lambda sign. So you are able to see like a lambda, right? Lambda, and it is a sign of dichorionic placenta. So that's the reason there is a great role for the ultrasound. So dichorionic twins are 80% with 2 placentae, and that gives the lambda sign. Whereas monochorionic twins only 1 placenta, 20% only, then that gives the T sign is what you need to remember. Blood chimerism. Where do you see? Which type of twins? Monochorionic but dizygotic twins. So what is the meaning of chimeric? What is the meaning of chimerism? When an organism contains cells derived from more than one distinct zygote, that's called chimerism. That typically happens in monochorionic dizygotic twins. So doctor, you need to have a clear understanding as to what are these terminologies all about. There is a single amnion, single chorion. This is monochorionic, monoamniotic twinning. This is diamniotic, dichorionic fused. Then this is diamniotic but monochorionic. And this is diamniotic, dichorionic and separated from each other. They are no more the roommates. So this is the mother of all MCQs. At what stage when the division occurs, what type of twinning will result? Your कल के exam में definitely एक question आएगा. This is called morula. When it undergoes cleavage between day 1 to day 3, you get dichorionic, diamniotic twins. This is the blastocyst stage. If the cleavage occurs between day 4 to day 8, you get monochorionic, diamniotic. This is implanted blastocyst. And when the cleavage occurs between day 8 to day 13, you get monochorionic, monoamniotic. This is already a formed embryonic disc. So when the cleavage occurs between day 13 to day 15, Siamese twins, conjoined twins paida hoga. One MCQ invariably comes from this table, doctor. Football लेना, screenshot ले लो और याद रखना. नहीं तो एक बुक लगो, लिख लो, याद रखना, डिस्कस करना, दोस्तों को पूछना, सब लोगों को सताना, फिर आप याद रखना कल के एग्जाम के लिए. Promise? Promise. Now, what is the condition which is being depicted? So this is an example of monoamniotic twins. No brainer. The main factor responsible for increased perinatal mortality. Why in twin pregnancies? Why perinatal mortality is high? Because of the prematurity. Twins predisposed to prematurity. Monozygotic twin with one healthy baby born at term and one dead mummified fetus. What is it suggestive of? Fetus preparacious. So what is the most common twin pregnancy presentation, doctor? Vertex. Now comes the next favorite topic. Amniocentesis, chorionic villus sampling. You have to be everything, anything about it, you should be ready. If you want to diagnose that Down syndrome at 11 weeks, what is the best way? Chorionic villus biopsy. Why? So you should know, doctor, differences. 10 to 12 weeks. 10 to 12 weeks. Chorionic villus sampling. 15 to 20 weeks is amniocentesis. Culture, amniocentesis 3 to 4 weeks. And termination of pregnancy. First trimester safe, chorionic villus sampling. Amniocentesis second trimester risky. Fetal loss is more with chorionic villus sampling, 0.7%. But accuracy is more with amniocentesis. Amniocentesis is much more traumatic psychologically for the mother because already pregnancy has started 15 to 20 weeks. जरा टाइम गुजर गया इसलिए जरा ट्रॉमेटिक होता है. 35-year-old female with previous history of birth of a child with Down syndrome, 18 weeks. Immediately what should be your answer? Amniocentesis. Chorionic villus or amniocentesis DNA analysis will not help you. Hemophilia A, sickle cell, Duchenne muscular dystrophy, DNA. But Tay-Sachs, you require biochemical evaluation, not DNA-based testing. The best period of gestation to carry out chorionic villus biopsy, every time examiner's favorite question, 10 to 12 weeks. Prenatal diagnosis at 16 weeks pregnancy. How do you do? Amniotic fluid, maternal blood, chorionic villi, etc., etc. Chorionic villus biopsy can diagnose Downs, phenylketonuria, sickle cell, but no neural tube defect. Earliest you can do chorionic villus biopsy by 11th week. Now comes androgen insensitivity syndrome. It is also called testicular feminization syndrome. इसमें क्या problem है? Karyotype XY. XY karyotype means you expect male. But what is the problem? Testis produce testosterone, but testosterone converts to dihydrotestosterone, but dihydrotestosterone receptor level resistance is there. So if the dihydrotestosterone receptors are not working, if testosterone is not functional, testis cannot descend into the scrotum. So testis remained in the inguinal canal. But this testosterone is converted into estrogen. So if anyone has estrogen, then breast will develop. So that is the reason phenotypically they are females, but karyotypically, genotypically they are males XY. So 16-year-old female presents with primary amenorrhea, phenotypically female, primary amenorrhea, never menstruated. They have a blind vagina, absent uterus. So what is the next investigation? Androgen insensitivity syndrome. You need to do karyotyping and prove it. A girl is having primary amenorrhea, grade 5 tila, breast buds developed, grade 2 pubic, but no axillary hair. That is testicular feminization syndrome. What is a very common cause for a female pseudo-hermaphroditism? That is, clitoris is enlarged, clitoromegaly. So it is a congenital adrenal hyperplasia that leads to female pseudo-hermaphroditism whenever the androgens are excessive. A 15-year-old female presents with primary amenorrhea. Her breasts are Tanner 4, but she has no axillary pubic hair, and a very common clinical vignette about testicular feminization syndrome. Now, androgen insensitivity syndrome, what do you have, doc? XY genotype, short vagina, ovaries are absent, pubic hair is absent, axillary hair absent is what you need to remember. So once more, primary amenorrhea, absent uterus, normal breast, scan, pubic hair. You will jump and answer tomorrow's exam. Androgen insensitivity syndrome. 20-year-old female with primary amenorrhea, no axillary pubic hair. Testicular feminization syndrome. So that is the story. Now the last topic for the today evening, doctor. Thank you very much. I thought after the intermission, how many will you come back? I'm so happy and thankful to all of you for once more rejoining. And tomorrow, don't forget, 3 p.m. every Sunday, like a church, we will have a test discussion. So please go to onlineMBBS.com, take the full-scale grand test by tomorrow afternoon, and be ready to join the discussion. Every Sunday we have a grand test and discussion. Endometriosis, let us talk about it. What is the best investigation to establish the diagnosis of endometriosis? Laparoscopy. So this is a very interesting topic, doctor, endometriosis. Gold standard for the diagnosis. Should not think anything else. Laparoscopy and histopathological examination of endometrial glands and or stroma. So while you are doing laparoscopy, keyhole you are watching, you look for a uterus, adnexa, peritoneum of the ovarian tissue, vesico-uterine fold, pouch of Douglas, pararectal space, rectum, sigmoid, appendix, cecum, diaphragm, everything. Inflate the abdomen with carbon dioxide and peep hole, right? Then 21-year-old girl with mild endometriosis, how do you want to treat? Mild means cyclical oral contraceptive pills, mild. So what are the various sites of endometriosis, doctor? Uterus, abnormal endometrial glands within the uterine myometrium, that is adenomyosis. Ovary में endometrium 30%, pelvic peritoneum 10%, bladder, vagina, rectum, pelvic colon, ligaments, वगैरह वगैरह. So you should know posterior surface of the uterosacral ligaments, anterior cul-de-sac, uterine wall, 30% of cases, ovary, another 30% of cases. You have to be very sure. So each of these questions, image based questions, बहुत आता है endometriosis के ऊपर. So please subscribe to incus.live, our portal www.incus.live. We will upload almost 10,000 image-based MCQs free for you to debate along with your friends on the answers and action points. It's like a Facebook. Posts, videos, sharing, request friend, everything similar to Facebook. Incus.live. So early lesions appear papular and red vesicles are filled with hemorrhagic fluid with surrounding flame-like lesions. Over time, these vesicles change the color. Endometriotic areas become dark red, bluish, black, cystic areas. Chocolate cysts of the ovaries, what are they? Very important presentation of endometriosis. The chocolate cyst, thickening of the tunica albuginea, vascular red adhesions underneath, on the undersurface of the ovary. So this is how a chocolate cyst looks like. कल के एग्जाम में पूछेगा. So can you see chocolate? Black chocolate is available for you. Endometriosis. So what are the classical triad of clinical features in endometriosis is the question of the examiner. Deep dyspareunia while having intercourse, very painful, doctor. Then subfertility, dysmenorrhea at the time of ovulation, there is a significant pain. Dysmenorrhea, dyspareunia, subfertility. Triad of clinical features, every USMLE job, FMGE job, कहीं भी job. This is one of the favorite clinical Vinet-based MCQ. So if you do bimanual pelvic examination, fixed retroverted uterus, bilateral pelvic tenderness, fixed or enlarged ovaries, and painful nodularity of the uterosacral ligaments, classical feature. And if it is a adenomyosis, that is all endometrium has gone and sit in the myometrium and the uterus enlarged. Adenomyotic uterus is enlarged but never more than 12 weeks in size, unlike fibroid uterus. So this is how you can see endometriosis, ovarian endometrioma, and a secretory endometriosis histologically. You should be very sure. So this kind of early peritoneal implants look like the blackened spot-like lesions on the serosal surfaces. This is an endometriotic cyst of the left ovary, a typical laparoscopic image. And these are the cluster of chocolate cysts. This is the raspberry spot of endometriosis. These are all the dense adhesions of endometriosis. And if you do MRI, typically you can see the presence of all that endometrial implants in various head neck cell structures. So how do you treat endometriosis? It can be medical, it can be surgical, or a combination. The medical management is mainly pain management, prevention of menstruation, so that you can restrict that progressive ectopic endometrial proliferation. Stop it, right? So surgical management is more definitive, and dysmenorrhea, subfertility, they can be improved by doing surgical management. So if the fertility is the main issue, the management should be towards surgical excision. Then you have to give a hormonal drug to reduce the menstrual flow. In fact, this medical therapy is called sandwich therapy before surgery, and pre-operatively, post-operatively, in conjunction with surgery, you can give sandwich therapy. Pain management of endometriosis. Oh, doctor, so much pain, doctor, at the time of ovulation. Endless nights. Hormones, combined oral contraceptive pills prevent the withdrawal bleeding by taking COCs continuously, and that prevents the retrograde menstruation. But COCs are the only effective prophylaxis, prevention against endometriosis. Medroxyprogesterone, especially depot form, is effective to reduce the pain symptoms, but long-term usage lead to osteoporosis. Then progesterone, if you give, you are inducing pseudo-pregnancy. Obviously, what is pregnancy? Pregnancy is a state of high progesterone. By giving progesterone, you are causing pseudo-pregnancy state, which is called Krishna's regime. So progesterone will lead to decidualization and atrophy of estrogen-dependent endometritic foci. That is the purpose of giving progesterone. How will progesterone help? All these endometrial glands, even in their ectopic position, they require the supply coming from estrogen. Somebody should go and oppose that estrogen. That is the purpose of giving progesterone, is what you need to remember. So medroxyprogesterone acetate, norethistone, dipomedroxyprogesterone acetate, they're all the ones which are basically used. But progesterone lead to irregular bleeding, weight gain, fluid retention, breast tenderness, mood changes, pseudo-pregnancy. Danazole, gestinone are used for endometriosis. There are weak androgens, progestogenic and anti-estrogenic. Then gestinone is the anti-progestin. And side effects are similar to danazole. You can use GnRH agonists. They will lead to hypoestrogenism. So that they not only decrease pain, but also decrease the size of the lesion. Then aromatase inhibitors. They can be used to antagonize the estrogen, but they can lead to bone loss. So what are the indications of surgical management? Any mild endometriosis but infertility. No more medical surgery. Endometrioma is there, but more than 4 centimeters in diameter. 4. 1, 2, 3, 4. Please don't forget. This is an MCQ. Endometriosis on the rectovaginal septum or rectal wall. Any failed medical therapy, intolerable side effects of medical therapy, they're all the indications. So, doctor, you should know clinical management of endometriosis thoroughly, because that is the favorite area of the examiner. So, as a teacher, my job is to study along with you, right? Good deal. Study along with you, every day study along with you, so that you will feel, "Arey bhai, aaj murli bharatwaj padh rahe hain, hum bhi padhenge," right? So that is most important. So what do you see in endometriosis, doc? Dyspareunia, infertility, chronic pelvic pain, they're all the classical features. Why there is a pain in endometriosis? Why NSAIDs give a relief? It is because prostaglandin E2 is the one which is pain inducing. Investigation of choice is laparoscopy in endometriosis. In endometriosis, you give gonadotropin releasing hormone to treat endometriosis. The most common site of endometriosis is ovary. So that is all about the today's evening doctrine. Shanti, Shanti, Shanti. So I want to see all of you tomorrow afternoon, 3 p.m. We'll have a Sunday test discussion. But please go back to onlinembbs.com, subscribe to the online test, 65 full-scale grant tests with the discussion, and become strong every day, right? Dr. Murli Bharadwaj is like Bournvita, Horlicks, petrol for your preparation to reach the required ignition to take off. No setbacks, no depression game, no thinking, no doubts, will I get the seat or not? You are going to become the topper in the top 1,000 ranks. Thank you very much and good night.